Good evening, everyone. I'm Jane Dixon-Weber, the Director of Education and Support Services at the National Fragile X Foundation. I would like to welcome you to this evening's webinar, Medication for Individuals with Fragile X Syndrome by Dr. Craig Erickson. It is our 7th annual webinar on this topic, and so Dr. Erickson is very gracious to give us his time again tonight. Before we begin, these webinars are made possible by your donations. Thank you for your ongoing support. Now, I would like to introduce Dr. Craig Erickson. He is the Director of Fragile X Research and Treatment Center and an Associate Professor of Child and Adolescent Psychiatry at Cincinnati Children's Hospital Medical Center. He provides clinical care for persons of all ages with Fragile X syndrome. His research focuses on targeted treatment development in Fragile X syndrome, including work to develop biomarkers for use in Fragile X targeted treatment studies. Welcome, Dr. Erickson.
Thanks, Jane. You know, I always love doing this, and I remember it's my 7th one, and my daughter turns 7 tomorrow. So I have it lined up in my head, and I've been back in Cincinnati, Ohio for 7 years. So all the 7s line up. So this is an incredibly enjoyable experience, and you know, I think that we've gotten great feedback about doing this, and I'm going to really take a practical bent on going through a number of questions and areas that people wanted me to address that have been submitted already. And then I think Jane's got some more questions, and we'll spend the whole, you know, the vast majority of the 90 minutes keeping it as practical as we can, fielding queries from families all over the place. I always start with a brief presentation, and I'm just going to highlight 2 research projects that are timely, that are ongoing. And the first thing to notice here is that this is the clinicaltrials.gov website. I really recommend this website for families. First of all, it's our taxpayer resource from the National Institutes of Health. And pretty much every trial that occurs in the United States is logged in this system. So you can see here that I searched the word Zynerba and Fragile X, and this is the Zynerba Cannabidiol study. I brought this one up to mention it because, frankly, there's a shortage of Zynerba patients enrolled in the country. And in order to do a fully scientifically rigorous study, we need to get more patients in the project. And the last thing as a stakeholder community you want is not to have enough folks in a project, have the project close, and then kick yourself that you didn't have enough of what's called study power. You didn't have enough scientific rigor with big numbers to answer the questions you're looking at. So this is a pretty important one if people have interest. It's ages 3 to less than 18, and it's noted there in this government site. And folks can go to this clinicaltrials.gov and read about this project, and they can read about a lot of other studies also. This is transdermal or gel cannabidiol. I probably have some other cannabidiol questions. I can talk about cannabidiol more this evening, but it's dosed in a manner that's thought to be appropriate dosing, and it's, you know, many-fold higher dosing than what we can buy kind of over the counter across the United States today. So, you know, I encourage people, if they have interest in this one. I think the one challenge has been what are called screen failures, which means some people are interested in being in the study. They go through a questionnaire and they're told that their child doesn't have the features or characteristics that would allow them to be in the study. And, you know, that's a challenge, but it's really, it's designed that way to ensure that what we're targeting, there's essentially enough of it to improve. And we can't be overly specific with families about exactly what's being looked for, because we would never want to bias you know, the entry criteria in that way. So again, this one really needs more patients. The safety profile is excellent. and we need to get it fully enrolled to answer these solid scientific questions. So I think there's a timeliness to that one. One other one I don't have a slide on is ganaxolone, or from Ovid Therapeutics, in kind of the adolescent and young adult age range. Still, has been extended, we've been told by Ovid Therapeutics, to be able to enroll more subjects. That's an open label project. So it's short term, but it's guaranteed treatment. You're getting the drug, but you don't know what dose you're getting. So we've had a few folks in Cincinnati in that project, and the open label part of it is nice. But you would be able to get some young adults into the Ovid project that, for example, maybe could not do Zynerba because they're over 18. And I know that over 18 part, we've had a ton of adults that have wanted to do the cannabidiol and Zynerba, but haven't been able to. And we really hope we can do adult cannabidiol studies in the future. And then the last one I want to mention, it is a slightly, I guess it is a local plug, but we've been trying to complete a study of novel medicine called AZD 7325 in adults with Fragile X, 18 to 50-year-olds, and we've got like 2 more spots for anyone in the country, and then we're done. So we really want to get this one completed. It's a well-tolerated medicine developed to treat anxiety with some really specific chemical properties that we think align with what's going on in individuals with Fragile X and their brain function. People have had a pretty good experience with it. Again, no tolerability issues, and we have 2 more spots. So this one is just in Cincinnati, Ohio. We fly people in from all over the country, and that's not an issue. It's covered by the project, and some people, stay in a hotel and visit and go back. And but it's for adults. It's 2-week treatment periods, high dose, low dose, and placebo. And we do a lot of EEGs with it. So we look at what the medicine is doing to your brain electrical activity. So this one's just about done. We got to get a couple more families involved, and then we hopefully will be able to have a readout on the data in early 2020, and I'll definitely be talking about it at the next International Fragile X meeting because we think it holds a lot of promise. So that's it for my brief slides. So I think I'm going to go off of sharing my screen, which I think I just did, and I will now move into the many important questions that folks have offered. And I think I've got the questions in front of me. Give me 1 second here to get them. So the first, yeah, Jane?
Can I just jump in real quick? So I just want to
Absolutely.
say thank you to everyone who submitted a question. I've tried to collate them as best I can so that Dr. Erickson can get to them, get to as many different topics as we can. And so we're going to do our best to cover everything we got. But if we don't get to your question, feel free to send me an email either later tonight or tomorrow, and we'll get an answer to your question. So with that, thank you.
Yes, and then what I always say on these is, people can contact me directly afterwards. I always have some people do that. I just showed that fragilex at cchmc.org, or my name, it's craig.erickson at cchmc.org. I'm happy to respond to email questions. If sometimes people participating or listening to this webinar, if it's kind of a pretty complex, individualized situation, I set up a ton of phone calls with people around the world and talk about stuff too. So, we just want to meet the need in any way we can. Our group works with people from infancy through older adulthood, and so even beyond the webinar, happy to reach out. And I do several calls like that with people I've never met, and we're talking on the phone each week. So the first topic, and I think this is extremely important, is anxiety, asking about medications in addition to or besides the selective serotonin reuptake inhibitors, or SSRIs. So first of all, had a nice paper come out with Jane and with stakeholder representation from the foundation, where we looked at surveys, and anxiety is just the biggest concern behaviorally and otherwise that families are reporting. And the foundation is working on a really nice anxiety survey to try to improve our ability to rate anxiety, to develop drugs specific to anxiety. So my final editorial comment is, the FDA is publicly not allowing us to target anxiety to get FDA approval in Fragile X, because the point is that anxiety is, in the FDA's opinion, an internal state that you have to self-report on. And our population of folks with Fragile X with developmental delays are viewed as non-accurate reporters. So that's why this anxiety survey that the foundation is working on, and that I know Jane has sent emails out, is so important, because we're trying to counter that government approach so we can try to move forward anxiety efforts with the FDA. Okay, now back to the practical question. So when we are treating anxiety and we've had someone fail a couple of SSRIs, escitalopram, Lexapro, citalopram, Celexa, fluoxetine, Prozac, sertraline, Zoloft, to name a few. Once we've had a couple of failures, one thing I like to do in sort of the besides category is we pivot to the serotonin norepinephrine reuptake inhibitors, or the SNRIs. The most commonly used one in our practice is duloxetine or Cymbalta. Had some good luck with this in both individuals with a full mutation and in premutation carriers. And I was asked about anxiety in carriers also. The other serotonin norepinephrine reuptake inhibitor that's commonly used is venlafaxine, or Effexor extended release, or there's a new version called desvenlafaxine or Pristiq. So those SNRIs, serotonin norepinephrine reuptake inhibitors, impact norepinephrine and serotonin in the brain, so they act a little bit differently, but they carry basically the same FDA approvals to treat depressive and anxiety disorders. So they're kind of in the same realm, but they're different enough that we've had some cases where people really respond to those SNRIs, like duloxetine's the most common one we use, when they failed the SSRIs, like the Paxils, Prozac, Zolofts, Lexapros, Celexas of the world. So that's our one move. We sometimes augment with a few different drugs. So if you're on an SSRI and you're doing okay, but there's room to improve, and you don't want to make the big step of like flipping an SSRI out for another primary anxiety medicine, sometimes we augment with a drug called buspirone or Buspar, which is FDA approved for generalized anxiety disorder. I view it as a pretty mild medicine. It doesn't have a lot of tolerability issues or adverse effects, but it also doesn't work all the time. So, you've got I'd say 33 to 50% chance maybe the buspirone augmentation is helpful. We sometimes augment with beta blockers. They're medications that are traditionally used to treat high blood pressure. They're often used to treat situational anxiety too. The classic, people that have to do public speaking sometimes take a low dose of a beta blocker if they have a lot of anxiety with that. The most common one we use to augment is propranolol, which is a FDA-approved beta blocker for hypertension. It's also been studied a lot recently for anxiety and autism. Sometimes that can be used to augment your strategy. We also augment at times with an antihistamine called hydroxyzine. The old trade name of that is Atarax. It's in the same family of drugs as diphenhydramine Benadryl, but it's a bit better for anxiety. So that one is also pretty well tolerated, can cause some dry mouth. So those are some of the more common strategies. Sometimes for really severe anxiety that's not responding to these augmentation strategies, in particular in some of our adolescents and into adults, when folks get a little bit older, excuse me, we use some of the medications called benzodiazepines, clonazepam, Klonopin, lorazepam, Ativan. Alprazolam Xanax is in the same family, but we don't use that one because it's pretty short acting and has kind of more of a yo-yo effect problem. But in that class, we most commonly use clonazepam or Klonopin, which is FDA approved to treat anxiety. The challenge with clonazepam is you can develop tolerance to it, meaning, it can help for a while and then kind of wear off. And sometimes people can get disinhibited on medications from that class, clonazepam. That AZD drug I talked about before is actually somewhat related to the clonazepam benzodiazepine family, but it doesn't have the tolerance and sedation issues with it. It's kind of like a refined medicine in that category. It's sort of like a newer generation, safer, better tolerated formulation, and that's why we're studying it. But so there's a lot of ways to kind of augment. When we've done big surveys of anxiety treatment through the Centers for Disease Control Forward program, a lot of clinicians list that they prescribe aripiprazole or Abilify for anxiety. I'm traditionally more of an Abilify, aripiprazole for aggression, self-injury, and severe tantrums prescriber. But undoubtedly, we get these situations where the anxiety can get so tightly linked to some of these more interfering overt behaviors, kind of reactive behaviors, that a medicine like aripiprazole can potentially help calm the whole state if people are getting quite agitated because of their anxiety, and then things may get better. So there's certainly some crossover there. Now, anxiety and premutation carriers. Our clinic does provide mental health care for premutation carriers, and we treat anxiety. I'm a big, we use SSRIs, of course, probably most commonly escitalopram in that class, but I do like the duloxetine SNRI medication, because the SNRIs, the serotonin norepinephrine reuptake inhibitors I mentioned, also can help with peripheral neuropathy and aspects of chronic pain. And sometimes our premutation carriers have those concerns also. So it can be duloxetine is also approved to treat fibromyalgia, for example, to kind of give a context that makes more sense. So I think that can be a good option, and we've got a lot of carrier moms with severe anxiety taking duloxetine with some success. The next area I was asked to comment on is treatment medications of aggressive behavior.
Craig, before you start there, could I interject? When you mentioned some of these drugs, could you also mention maybe some levels or dosage?
Oh, dosing. Yeah, Jane, sure. Sure.
Thank you.
So in the SSRI realm, typically, the most commonly used, we use escitalopram, Lexapro, which has very limited drug-drug interactions. That's typically dosed from 10 to 20 milligrams a day, 20 is a max. Sertraline or Zoloft, very commonly used for anxiety and Fragile X. Typical dose range of that drug is about 50 to 200, so it has a bit of a wide range. One caveat I would give with the SSRIs is to treat, they're also antidepressants. They're approved for anxiety and depression. To treat anxiety takes higher dosing. So a lot of times we are reaching the higher ranges of what I'm going to mention here. Fluoxetine or Prozac, we typically dose about 20 to as high as 80 milligrams a day. And if we're pushing 40, 60, 80, we do that in, really with an anxiety as a target. The duloxetine or Cymbalta that I mentioned is typically dosed, average dosing is 60 a day in adolescents and adults. You can sometimes get by with as low as 30, and max dosing is 120. The FDA allows dosing up to 120. excuse me, technically, dosing above 60 milligrams has not globally shown significant added benefit, even though on an individual patient level, we have a lot of people that do really well on 90 or 120 milligrams. The venlafaxine extended release Effexor, which is related in the same class as duloxetine, is dosed up to 300 milligrams a day. And the Pristique desvenlafaxine that I mentioned, we dose up to 100. I saw a young woman with Fragile X today on 100, and that's max dosing for desvenlafaxine or Pristique. The other stuff I talked about, the augmenting strategies, buspirone, you can take up to about 90 milligrams of it a day. It's divided 3 times a day, so the buspirone requires more frequent dosing. Typically, we start 5 3 times a day, 10 3 times a day, 15 3 times a day, up to 23 times a day, and gradually adjust. And I think typical buspirone augmentation dosing is about 30 to 60 a day. The beta blockers I mentioned, propranolol, which can help anxiety, has a really wide, kind of wild dose range. You know, it's an extended release and immediate release formulation. The immediate release, we dose about 10 to 30 milligrams up to about 3 times a day. Extended release, we have patients that take up 240, 300 of it a day. The challenge with that is you can monitor blood pressure with it to be sure blood pressure doesn't drop, and there's a bit of a risk of headaches. The clonazepam, Klonopin I mentioned, the benzodiazepine, typically we start at a 0.25 to 0.5 milligrams a dose, and we can dose people up to 2, 3, 4 milligrams a day. The clonazepam tends to have a lasting effect for about 8 to 10 hours if you're responding well to it. The aggressive medication, so aripiprazole or Abilify in risperidone or Risperdal are the most commonly used medicines in Fragile X to treat aggression, self-injury, and severe tantruming behavior. And I was asked also about the interplay of anxiety and aggression. And I think that's where we see a lot of individuals prescribed aripiprazole. So aripiprazole, 5 to 20 milligrams, maximally 30 milligrams a day. That's available, the aripiprazole, in a liquid, in a pill, in a rapidly dissolving form that goes in the mouth, and it's available in a shot that you can get a shot every few weeks if you're really not able to take any oral meds or averse to that. The risperidone is dosed about 1 to 6 milligrams a day. And risperidone tends to be dosed 2 to 3 times a day. Aripiprazole, most commonly, we dose it once a day. Sometimes we split dose it twice a day. Both of those medicines, aripiprazole and risperidone, are called newer generation antipsychotic medications. With that indication, they both also treat schizophrenia and bipolar disorder. They're FDA approved in autism. And in autism, they're approved to treat the aggression, self-injury, and severe tantrums. They do have associated weight gain, which is a problem. I would say 30, 40+% of folks on those agents can have a significant weight gain, which is probably multifactorial in that people both eat more and their metabolism may be altered. Luckily, we've published papers, and metformin, which I don't know if I have a metformin question. I almost always do, and I'll talk about metformin. But metformin is being studied specific to Fragile X, but it's also been shown to block weight gain associated with medicines like risperidone and aripiprazole, Risperdal and Abilify. So we have some nice papers that show when we add metformin to these drugs, a lot of times we can kind of stop the weight gain, which is really nice. If those drugs fail, other options we use are quetiapine, Seroquel, which typically we dose up to 1,000, 1,200 milligrams a day. Dosing's different, maybe as low as 100 milligrams. We tend to dose quetiapine 2 to 3 times a day in divided dosing. I've had some folks with Fragile X really respond well with quetiapine that have not done well on the other drugs, but we're not great at predicting on who's going to do better on which of these medicines. Quetiapine's in the same class as risperidone and aripiprazole. For people that are having terrible weight gain problems and they can't take metformin or metformin didn't help, we dose ziprasidone or Geodon, which is in the same class as the other anti-aggressive drugs I talked about, but it doesn't cause weight gain. It's in a capsule, and that's pretty much the only way to get it. So the anxiety and aggression, final word about that, the interplay can be really intense. It can be challenging, though, because once you get to a pretty physically aggressive level, I think sometimes using some of the classic anxiety-only treatments like an SSRI, those medicines, the SSRIs take some time to work. And I think the kind of aripiprazole, Abilifys of the world probably disentangle anxiety and aggression that's interlinked probably best, and maybe gives you a chance to only need to take a single medication too. So I think that's been some of the positives. I've got some questions about ADHD besides stimulants. And then I think maybe to address both focus and hyperactivity, and I'll try to talk through that. So so non-stimulant options, guanfacine or 10X is available in a immediate release and a extended release form. The extended release form is called Intuniv. We certainly use guanfacine in Fragile X in both forms. The immediate release, we dose about, I would say 1 to 4 or 5, maximally 6 milligrams a day, 2 to 3 times a day, because it lasts about 4 hours, divided up guanfacine. The Intuniv extended release guanfacine we take in the morning. Dosing of that's about 2 to 5. Maximally, I got a few people on 6 milligrams a day extended release. We use guanfacine a lot in autism. It's much better studied in autism than in Fragile X. There are good placebo-controlled guanfacine trials, and I participated in those in autism. Less used in Fragile X, but it is a good non-stimulant option. It also helps tics, which can be a benefit. And then it has some chance of causing constipation. It also is a blood pressure medication historically, but at the doses we use doesn't really have a significant problem with that. And it doesn't tend to be too sedating. There's another ADHD medicine non-stimulant called clonidine that's available in extended release called Capve. You need to swallow Capve because it's extended release. If you take immediate release clonidine, it tends to make people kind of tired, so it's hard to take it during the day. Some people are resistant to that. We use clonidine for sleep, and I'll talk about that under sleep. The extended release clonidine Capve is dosed about 0.1, 0.2 milligrams a dose, and can kind of last throughout the day, and is FDA approved to treat ADHD. One other area that I think is somewhat limited use in Fragile X, but is atomoxetine or Strattera. It's a capsule form ADHD medicine. Typically, we dose that one up to about 1.2, this is a little technical, 1.2 to 1.8 milligrams per kilogram of body weight, or a maximum of 100 milligrams a day. And it comes in a bunch of funny sizes like 18s and 30s and 40s and 50s. The atomoxetine takes a little while to work treating ADHD. And there's just not a lot of reports of its use in Fragile X. We've used it some with some success. We use a lot of stimulants to treat ADHD though, but there are obviously certain stimulant side effects like can reduce appetite. If you take it too late in the day, it can be hard to sleep. That's a controlled substance. The other ones I talked about, atomoxetine, guanfacine, clonidine, none of those are controlled substances, so they have those advantages. If anyone wants more information on some of the more unusual ones, they can certainly contact me and we can go into more detail, like with the atomoxetine, Strattera, and some of the other formulations. But we certainly have options. So if stimulants are not for your child, there are certainly a number of different things to try. The next question asks specifically about focus. And, for focus, I find the stimulants tend to work the best. The non-stimulants, like the guanfacine I talked about, seem to be better for hyperactivity than some of the pure focus, even though that's kind of a tricky question, because if your child's less hyperactive and constantly on the move, their focus may be better too. But I think of the stimulants as best for pure focus, and some of the non-stimulants I mentioned to help more with hyperactivity and impulsivity. Another question about anger, and I think when we think about anger, the real question is, what's driving it? Is it driven by a mood issue, like a depressive picture? And whenever I think about depression in our populations, I really focus on, people may not say they're sad or angry, but they may change what they're doing, like their sleep patterns off, or they're eating more or less, or they're not enjoying stuff they used to otherwise enjoy. If I start to think there's a depressive picture like that, I'll really treat mood with a lot of those medicines I mentioned that also treat anxiety. So that's something to think about. If you're seeing a real kind of moodiness and anger in your child, I think that's something to think about. Like, could they be getting a bit depressed, and it's not super obvious, because they're not necessarily going to tell you they're sad. But I think that sometimes angry mood, if it's associated with sleep changes or interest in reduced interest in activities someone otherwise like to do, that can be a good marker of treating a mood issue. And then we really would treat mood issues with the selective serotonin reuptake inhibitors, the serotonin norepinephrine reuptake inhibitors that I mentioned before. So next, moving on to sleep. So I have an algorithm for sleep. I teach a lot of doctors too. I have my whole career. I teach medical students, fellows, residents, junior faculty, anybody. We go with sleep. Number one, behavioral sleep approaches. So have a good sleep routine. If you have access to behavioral psychology, behavioral support, I think that can be helpful. I think a lot of people, and including our family, with the best of intentions, if your child's like coming into your room or into your bed to sleep, and then they get used to that, it kind of perpetuates itself. So there's certainly behavioral things that you can do to help sleep. From a medication standpoint, we are melatonin first. If it doesn't work, and melatonin, we typically dose about 3 to 6 milligrams a day, maximum of 10. Melatonin is very safe. After that, Benadryl, which we just dose like it's on the bottle, or if your child can take pills like it says. Benadryl is diphenhydramine. So adult dosing of that's like 25 or 50 milligrams. Kids dosing is typically in liquid form on the bottle. And then, so we go melatonin, then Benadryl. If those fail, we're really in the prescription medicine world. And my first prescription medicine is trazodone, which is an old antidepressant that at low doses is really good for sleep. And in kids, maybe like under 12, we may do 25, 50 milligrams at bedtime. Adolescents and adults, 50 to as high as 300 at bedtime for sleep, for insomnia. And that's a good medicine. It's not a controlled substance. It's non-addictive, non-narcotic. You don't have to take it every night, so you can take it some nights, not take it other nights. And trazodone could be a really good option. So after trazodone, the next one we do is clonidine, which I mentioned before, which is also considered an ADHD treatment in extended release form. But immediate release clonidine can be really good for sleep. And in younger kids, like kind of prepubertal kids, maybe a 0.05 to 0.1 milligrams at bedtime is typical. In adolescents and adults, more like a 0.1, 0.2 range of clonidine, and that really can help a lot of people get to sleep okay. It's the kind of medicine, though, you probably want to take it regularly versus kind of take it one day and not the next. And again, it's originally FDA approved for high blood pressure, but it can have a good sleep use. After clonidine, we move into some of the other FDA approved sleep aids that are related to the benzodiazepines I mentioned before. So you'll hear about drugs like Ambien, Lunesta. We prescribe an older one that's cheap and easy to get covered called temazepam that sometimes can be really helpful for severe insomnia. We don't use these really in younger children, but in adolescents and adults, we'll use some temazepam. Temazepam, we'll dose it 7.5 to up to 30 milligrams a day, and it comes in 7.5, 15s, 22.5s, and 30s. And we have some good luck with temazepam for sleep. Sometimes if you get really anxious in the evening, clonazepam, the anxiety medicine, can be helpful. But we really like to fail a bunch of other sleep options before we get to those medicines, because the temazepam I mentioned, clonazepam I already talked about, you can get a tolerance to them, and then they may not work as well. So that can be a bit of a problem. So melatonin, diphenhydramine, Benadryl, trazodone, clonidine. Oh, there's one medication I forgot that we used before temazepam and kind of after clonidine, and it's called mirtazapine or Remeron, and it's also an anxiety medicine. So I probably should have mentioned it in the anxiety area. It's FDA approved to treat, anxiety and depression, and you take it in the evening, and it also helps sleep. The downside is it can cause some increased appetite, which is an issue. It's dosed 7.5 to 45 milligrams. Lower dosing actually helps sleep more, which is a little unusual, but that's mirtazapine, and we use that for sleep after clonidine, and I should have mentioned it under anxiety, because especially if people are not eating when they're anxious and they do not have weight concerns, mirtazapine can be good for anxiety and help sleep. So that should be on the sleep algorithm too, mirtazapine. So like 7.5 milligrams of mirtazapine at bedtime is a pretty good sleep dose, but more like 15 to 45 milligrams is a anxiety kind of dose. And mirtazapine's in its own class of drugs. It impacts serotonin receptors, but it's not an SSRI. So it's a little bit different that way. Next questions relate to self-injurious behavior. We treat self-injurious behavior with medicines like we treat physical aggression. We don't really differentiate. There was some lore about using naltrexone to treat self-injury. Never been a big believer in that. Don't think there's a ton of evidence. And we've had some people with some liver dysfunction issues. And I once had a young child with Fragile X develop really terrible vomiting on naltrexone, and it became a dangerous situation. So we just go after self-injury with aripiprazole and risperidone like we treat physical aggression in the same doses I talked about earlier. Options to sertraline. Not sure exactly what's meant by that, Jane, if it's kind of a dosing question or other options other than sertraline. We dose sertraline 50 to 200. In the same class, we use a lot of Lexapro or escitalopram with good success, dosing 10 to 20 as an SSRI. Sometimes we use fluoxetine or Prozac, 20 to 80 milligrams a day, most typically. So, the SSRIs are tough because it's hard to know which one your child's going to respond to. Sometimes family history of response is a good predictor. Sometimes if we're having tolerability issues, we can get what's called pharmacogenetic testing to look at how someone metabolizes drugs. It's not frequently super helpful with the metabolism issues or the metabolism test with pharmacogenetics. But, you know, if you're having poor tolerability or a bunch of different drugs don't seem like they're working, your child could be a rare, fast, or very slow metabolizer, which can help inform drug selection. And certain drugs may be better than others. While I'm talking about metabolism, one drug that we use a lot in autism that I think is probably underused in Fragile X is called paliperidone or Invega. It's the active ingredient in risperidone in a time-release formulation. And we have really great luck with that medicine. It's dosed 3 to 12 milligrams a day. It's got some pretty good tolerability. The weight gain risks are the same, but you can just take it kind of in the morning and it lasts all day, which is really nice. I think that can be really positive. And that's paliperidone for aggression, self-injury, and severe tantrums. The next question is about panic attacks and medication treatment. So I think the first thing to think about is panic attacks are really anxiety manifestations. So we got to treat anxiety. And this is the same with a question I have about selective mutism. Selective mutism is an anxiety disorder, and so is panic disorder, and panic attacks are driven by anxiety. So we got to go at those, treating anxiety hard. And again, therapy can be really helpful, but you know, talking about medicines, SSRIs often at higher dosing, serotonin, norepinephrine reuptake inhibitors that I mentioned, SNRIs, augmenting with other medicines, which could be buspirone or hydroxyzine or potentially the propranolol beta blocker if needed, can be helpful. But panic situations, if you know a situation is going to provoke panic, the clonazepam, Klonopin, and related benzodiazepines can be really helpful for panic also. In particular, if you have situational issues, to take ahead of time can be pretty helpful. And for that, clonazepam situationally, we typically do about a 0.5 to 1 milligram at a time. And I write a lot of orders. I don't know if I have questions tonight about PRN medicines, but I write a lot of orders about what medicine do you take to go to the doctor or the dentist or get on an airplane. And those tend to be the same medicines that can acutely help panic attacks or can prevent panic attacks if you know it's going to be a panic-inducing situation. And for those, the clonazepam is one of our most commonly used medicines. Sometimes lorazepam or Ativan is in that same class with that same use. Will we go at it that way? So selective mutism, it's an anxiety disorder. We see quite a few cases of selective mutism in full mutation females, and we aggressively treat it with anxiety medicines, including high-dose SSRIs and some of the augmenting strategies I talked about. Selective mutism, again, I think having aspects of non-medication therapy, like in just about all these areas, can be really helpful too. Violent outbursts, violent physical outburst, aripiprazole, risperidone, quetiapine that I mentioned before. If you're gaining weight on all of them, ziprasidone. Sometimes we use older agents. I should say this. We treat a lot of drug-resistant aggression, unfortunately, in some cases. We use haloperidol or Haldol, which we dose about 2 to 3 times a day with doses about 2 to 15 milligrams, kind of a wide range, maybe as high as 20 milligrams a dose. Haloperidol was really well studied in the 80s and 90s in developmental disorders to treat aggression and self-injury and severe tantrums, but it lost favor compared to aripiprazole and risperidone and the newer drugs because it has a higher rate of abnormal movements, which are called extrapyramidal symptoms, which can be like a muscle twitching, jerking, stiffening, and higher rates of also drooling and sometimes tremors. So because of that, we don't use as much haloperidol, but sometimes it works great, and you can pair it with a medicine called benztropine that can be really helpful to treat the side effects of haloperidol. So that's another option if, you know, the aripiprazole and the risperidones of the world aren't cutting it, to go to some of the older antipsychotic medicines. You just have to watch for tolerability. Seizures. So, you know, I'm not a neurologist and an epilepsy treatment expert. I would have a couple of seizure-related comments. One is, when we're trying to do behavioral medicine management with people that are having out-of-control seizures, it's really hard because I think seizures really have an impact on behavior. And the seizure state of the brain certainly impacts behavior. Sometimes anti-seizure medicines like valproic acid or Depakote can also have some real positive behavioral effects. And for example, valproic acid is FDA approved to treat bipolar disorder and epilepsy. That drug is dosed really widely, and you get levels of it to track the amount in the system. But, you know, typical dosing 500 to maybe 2,000 milligrams in a broad sense. But after about 5 days, you get a valproic acid level. So sometimes treating epilepsy can really help behavior too in different ways. But I would say, you know, the national expert in full mutation epilepsy treatment is my friend Liz Berry-Kravis for sure. Questions about treating constantly wanting to eat and obesity. This is a big issue. People may or may not have heard of this concept that I think, I may be wrong, but I think Rondé Hagerman, like so many of the foundational concepts in our field, came up with a concept of a Prader-Willi phenotype in Fragile X, which is a scientific way of talking about some people with Fragile X just have these massively insatiable appetites, and people with Prader-Willi have insatiable appetites too. Prader-Willi is a different genetic cause of developmental disorders. And we're not saying that people with Fragile X have Prader-Willi, but it kind of looks like that. And we certainly have some of those patients, and they just eat and eat and eat constantly. And metformin is probably a #1 treatment. Second would be, you know, if they also have ADHD symptoms, using stimulants can be really helpful. Amphetamine salt derivatives and methylphenidate derivatives, because they can suppress appetite and treat ADHD. And then if those options aren't working, then we really go at topiramate or Topamax, which is a seizure medicine that also causes some weight loss. So those are a few different options. Sometimes it's really hard to treat though. While I'm talking about dosing, the ADHD stimulants, methylphenidate and its derivatives, including extended release, maximum dosing is typically 2 milligrams per kilogram of body weight, or kilograms, 2.2 pounds. So if you weigh 100 kilograms, then you weigh 220 pounds. And maximally, you can take 2 milligrams of methylphenidate per kilogram of body weight. For amphetamine salts like Adderall and Vyvanse and Adderall XR, they're twice as potent. So that's 1 milligram per kilogram max generally. So those are some basic stimulant dosing guides that we use. And I'm happy to answer more about specific stimulant formulations. Helping a child become aware of when they need to use the toilet. That is a quintessential behavioral support, behavioral psychology question to me. And we work with a wonderful psychology lead at our center, Rebecca Schaefer, who helps a ton of families with toileting. And I know there are resources around the country. And if people have some specific toileting questions, you can email me or our FragileX at cchmc.org, and Dr. Schaefer can talk with you. And we do a lot for behavioral help with toileting. For those, but at the same time, I don't think there's a great medication for toilet training. I think if there are specific interfering behaviors, or there's really bad focus, or your child's like so hyper they can't sit still even to be on the toilet, then I think we can treat those areas and give you some support. But the pure behavioral part, I think taking a behavioral therapy bent, it really works well. On a somewhat related note, bedwetting overnight, or technically called nocturnal enuresis, can be treated with medication with something called DDAVP. And it can also be treated with some behavioral and other approaches and something called a bell and pad, which is like a bed alarm at night that vibrates if it's wet, and then that wakes somebody up and they go use the bathroom. So there's some different approaches there. So moving on, the latest on metformin. So there's my metformin question. And it asks about dosing. So metformin is undergoing multiple studies. If you go to clinicaltrials.gov, I encourage you to put in metformin and then Fragile X and see what's out there. There's been a study ongoing in Canada, California Davis and Rondi Hagerman's group in Sacramento. And then recently, a group in Rowan in the New Jersey area have been initiating a metformin study. So there's a lot of metformin studies. How do we use metformin? Typically dose it in younger children. If we're using it 250 per dose, we dose it at breakfast and dinner. We go up to 500 milligram per dose, starting dose in adolescents and in adults. Max dosing is 1,000 twice a day, and we dose it at breakfast and dinner. There's also an extended release metformin, and I believe the maximum extended release dose is 1,500. I'll look it up real quickly while I'm talking, so I give you the right information. But extended release metformin sometimes is helpful. You can get metformin in a liquid, but the manufacturing of it has been like really confusing. Sometimes we can get it, sometimes we can't. Maximum extended release metformin is 2,000, which is the same as immediate release, except the extended release you only have to take once a day, but you have to swallow it. Immediate release metformin we take at breakfast and dinner. The biggest problem with metformin is that it can cause stomach upset and loose bowel movement sometimes. So that can be a risk. We use a lot of metformin to treat weight gain associated with other medicines. And I think the jury's really out on these Fragile X specific effects. Is it helping cognition? Is it helping anxiety? Those kind of things. I've had a couple of families tell me they think it has. I've had some families tell me it hasn't. So I don't think we know the Fragile X specific answer, but I can say that for the weight gain, where we see these body mass index curves going way up, it can certainly be helpful. So, and we talked about the dosing. Tolerability of metformin's been pretty good, better than I thought it was going to be when I started using it 7 or 10 years ago. Not a lot of monitoring you need to do with it. Next question is about cannabidiol trial. I talked about that a little bit at the beginning. And I'll talk about the trial, and then I'll talk about just cannabidiol in the world, because you can buy it. Cincinnati, Ohio, I mean, I could walk, and I don't live in the main city, but I could probably walk to 4 or 5 places and buy cannabidiol now. It's everywhere. So in trials, it's a Zynerba proprietary gel that's rubbed into the skin at 250 or 500 milligrams or placebo initially. And then after the placebo-controlled study, it is open label, meaning you're guaranteed to get it. It's quite high dose. CBD, used to be just tinctures and oils and stuff. Now I find families most commonly telling us that their child's taking CBD gummies. Gummies are most commonly about 25 milligrams, sometimes they're 10 milligrams. And the bottle sometimes say take 2 a day, but that's about 10% of the Zynerba dosing. So, it's hard to take over-the-counter CBD and approach the research-based Zynerba dosing. The potency of the Zynerba drug is just way higher. Other CBD things. Well, we've had some people that have had their child taking CBD and they've tested positive for THC because, you know, CBD is not really regulated, and there certainly could be impurities with it. I think every week there's new CBD manufacturers, it seems like. It's a massive moving target. I've had a lot of families try it over the counter. Haven't heard a ton of stunning success, at least in what's available. Is that a dosing question? It's certainly possible. It's unfortunate we don't have a CBD clinical trial in adults, because I think that would be really useful. We do have the Zynerba trial in 3 to less than 18-year-olds, and that's very high dose formulation. So the other thing I'd say about CBD, I gave a talk to developmental pediatricians this morning about CBD, and it can interact with other drugs, even though it's really like kind of a dietary supplement essentially. So I think you need to let your doctor know, or whoever's prescribing stuff for your child, that they're taking CBD, because it can have some drug interactions, and it can kind of increase levels of certain medicines. And so certainly be forthright about it, I think, is key. The next question is, how much CBD should you try if you can't get in a trial? You know, I don't know. It's kind of hard for me to fathom telling somebody to take 20 gummies a day, because, again, there's potential impurities and other things in them. You know, if you want to try to match the Zynerba dosing in a milligram basis, that would be taking a lot of CBD. So we generally don't recommend that much, because, again, you don't know exactly what's in it. I get asked about full or broad spectrum CBD. I'm not really sure what that means, but it could mean CBD plus other things like low amounts of THC. You know, my opinion is that CBD is well, this is an opinion, it's true. CBD is a totally different chemical than THC. They just both happen in nature to exist in the marijuana plant. CBD is being studied extensively in anxiety disorders, PTSD. It's being studied in autism. We're studying it in Fragile X. It's FDA approved to treat severe epilepsy. That CBD, cannabidiol, has nothing to do with THC. So they're just co-located. So in no way should anyone think, well, if CBD is good, maybe THC is, because that's just, it's almost happenstance they're in the same plant. So I really parse them out in my brain. And I think CBD has a good safety profile. You got to tell your doctor because of drug-drug interactions, but it doesn't have toxic organ effects. In the U.S. Farm Bill of 2018, passed in December of last year, essentially removed regulation of CBD-only products and hemp products that don't have THC in them. So unfortunately, the FDA operates years behind, and they're regulating the Zynerba study like we're studying cocaine or methamphetamines, which makes it really complicated, even though it's just CBD that, you know, I could buy at, you know, 3 convenience stores in a video store. In Ohio, you know, we always wondered, how did video stores stay alive given all the online content? Well, we found out they now stay alive by selling CBD, because family video stores here in Ohio are now big CBD suppliers. So that just shows it's everywhere. But don't think CBD and THC have anything to do with each other. So that gets me to the question of medical marijuana and THC. There is no evidence that medical marijuana or THC has a positive effect in Fragile X syndrome. In areas where it's been legalized for a time, like Colorado, I've talked to my colleagues there at, for example, Denver Children's Hospital and others, and haven't heard a lot of great reports of impact of medical marijuana that, I mean, not even medical marijuana, just, I guess, recreational marijuana. It's very controversial in the autism field too. Ohio has legalized medical marijuana, and the government, the Marijuana Control Board, was going to approve autism potentially as a reason to take medical marijuana. But I'll say publicly that I was one of many physicians that wrote letters against aligning autism with a medical marijuana card because there's just not good evidence to do it. And there's certainly some risks of giving THC to people with developmental disorders that could have psychotic-like or disinhibited reactions. So I think we got to do good research in neurodevelopmental disorders.